All right, great to be here with all of you. Welcome. We have a lot to go through today. I would love you, though, to jump in either in the chat or, excuse me, or just to unmute and talk anytime you have a question or want to, delve a bit deeper into something. I've got a bunch of stuff here. We can easily skip over certain bits and spend more time on other bits if they're, if certain things are of more interest to you, and we can go off on little side tangents if that's valuable. So please don't hesitate to just interrupt me if there's something you want to delve into. All right, we're going to talk about Pilates for spondylolisthesis and Pars fracture. So the first thing is we're going to do a little exercise to pronounce spondylolisthesis, because that's kind of a bugbear, I think, for a lot of people. And the kind of get out of jail free card is you can just call it spondy, because that's what most physiotherapists, and because physiotherapists are just humans with regular vocal apparatus like the rest of us. Most of them can't pronounce it properly either. But it is actually relatively easy to pronounce if you just practice it and break it down. So say it with me. You don't have to unmute because it'll sound like a cacophony because we're all out of sync, but just please do say this out loud. Spondylolisthesis. 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 All right, and so the way to get really good at saying that fast is to start out by breaking it apart into those two separate parts, and then to say it together slowly, and then to gradually increase the speed until you can just say spondylolisthesis anytime you want, if that's something that you feel is important enough to dedicate a few minutes of your life to achieving. All right, spondylolisthesis and pars interarticularis fracture. Here we go. We are going to talk through the fact that spondylolisthesis is not a specific cause of back pain. Sciatica, which is leg pain, which is associated with spondylolisthesis, is complex and multifactorial, and it's often related to whole person factors, not just what's going on in the low back. And that surgery and all forms of exercise seem to work equally well for spondylolisthesis, and Guideline-care is a reassurance and advice to stay active. Okay, that's the end of the lecture. Hope you enjoyed that. Thank you very much. Do you have any questions? No, just joking. All right, we're going to go into a little bit more depth for each of those things. All right, spondylolisthesis is not a specific cause of back pain. So when I say specific cause of back pain, I'm using the terminology in a very particular manner. And so when I say specific, I'm using specific as defined by medical literature and current guidelines. And these are the most current guidelines. The American College of Sports Medicine's Guidelines for Exercise Testing and Prescription, 11th edition. This is the 2020 edition. And if you're interested in working with people who have either perfect health or imperfect health and giving them exercise, this is the best gold standard guideline for that. It'll tell you about low back pain, osteoporosis, pregnancy, Parkinson's disease, all kinds of different scenarios for people, older adults, kids, etc. So, and it'll give you the gold standard exercise prescription. This was the textbook in my master's degree in clinical exercise physiology, and it's a pretty standard textbook in postgraduate exercise courses around the world. All right, and I've got no affiliation with the ACSM. I just like their book. So if we go to page 172, and look for what's the definition of low back pain. Low back pain is defined as pain, muscle tension or stiffness localized below the rib margin and above the inferior gluteal folds, with or without leg pain. Right, so let's just deconstruct that for a second. So the rib margin is, if you put your hands on the sides of your torso and feel down the rib cage until you run out of ribs, well, that's the rib margin. Where you run out of ribs, that's the rib margin. And the inferior gluteal fold is the happy smile in your butt, okay? where your butt meets your leg. So again, if you just put your hands on that spot where I guess it's if you had a visible panty line or something, that's where it would be. Okay, so in between the rib margin and the gluteal fold, that is low back pain. So if there's pain in between those regions, according to the current guidelines, that's a definition of low back pain, with or without leg pain. All right, so is that low back pain? Yes or no? Thumbs up for yes, thumbs down for no. That is low back pain. What about that? Low back pain? That's low back pain. What about that? Isn't that sacral pain? Yes, it is, and it's also low back pain. What about that? Low back pain? Yes, that is low back pain. What about that? That is low back pain, because let's look at the definition of low back pain. Low back pain is defined as pain, muscle tension or stiffness localized below the rib margin and above the inferior gluteal folds, with or without leg pain. With or without leg pain. So, according to the ACSM, this is low back pain. Now, plainly, the leg is not the low back, right? I mean, did the ACSM miss out on primary school anatomy? The leg bone connects to the hip bone. No, they're not confused between what's the leg and what's the low back. The reason they define low back pain in this manner, there's a pretty good argument to say if there's a pain in your butt, that's not your low back, that's your hip. And if there's a pain in the back of your calf muscle, that's not your low back, that's your hip. So anatomically, of course, the leg's not the low back, but the reason they define low back pain in this manner is because the treatment is the same. Because we're interested in giving exercise to these people. So for the purpose of giving exercise to people with pain localized in the back and people with pain in the back with leg pain, the treatment's the same. So we categorize them together. All right. Further, ACSM, individuals with low back pain can be classified into one of three broad categories. Low back pain potentially associated with another specific spinal cause, e.g. cancer, fracture, infection, ankylosing spondylitis, or cauda equina syndrome. All right, so this is the definition of the word specific that I'm using in this context. And this is the generally agreed medical definition of the word specific in relation to low back pain. So specific low back pain is low back pain caused by basically a medically serious issue, something like cancer, a spinal tumor, a spinal fracture, infection within the spinal cord, ankylosing spondylitis, which is a neuroimmune / genetic condition where your own immune system attacks your spine, and cauda equina syndrome, which is a medical emergency where there's a major compromise to your lower spinal cord. So all of those things are classified as specific causes of back pain. So that's the first category. The next category is low back pain potentially associated with radiculopathy, which is pain down the leg or numbness down the leg, or spinal stenosis, which is narrowing of the spinal canal, and non-specific low back pain known with no known pathoanatomical cause, which encompasses over 85% of all cases. So things that are not specific, e.g. things that are not cancer, fracture, infection, ankylosing spondylitis or cauda equina syndrome are defined as non-specific low back pain. Okay, which doesn't mean that the pain is not in a very specific location, doesn't mean that the pain is not aggravated by very specific activities or positions, just means that we can't accurately identify a specific pathoanatomical cause for the pain. Right? Doesn't mean the pain is not real, just means there is a cause, but we don't, with our current technology, our current understanding of science, we can't necessarily identify the cause of that pain. And so, more than 85% of pain in the back falls into that category. So that shows you how much we know about back pain at the moment. All right. So first I just want to get, in terms of talking about what spondylolisthesis is, I want to first just talk about this term spondylosis, which kind of looks the same and kind of sounds a little bit the same, but is not the same. Spondylosis is an umbrella term. Spondylo means vertebra, means a spinal bone. Okay, so when you think now about spondylolisthesis, well, that is a word comprised of spondylo plus listhesis. So it's, whatever a listhesis is, which we'll find out in a minute, it's a listhesis of your spinal bone. Okay, and spondylosis is an osis of your spinal bone. So what's osis? Well, osis means an abnormal state or disease. Okay, so spondylosis is not a diagnosis. It is an umbrella term that says there's something, literally means there's something wrong with your spine. Right? It's like saying you have an illness. It's not a diagnosis, it's a generic term. So spondylolisthesis is a form of spondylosis. Disc bulge is a form of spondylosis. Non-specific back pain is a form of spondylosis. Arthritis of the spine is a form of spondylosis. All right, the next thing I want to talk about is pars fracture, because often these are associated with spondylolisthesis, and it's thought to be the case that sometimes pars fractures progress to become a spondylolisthesis. In your vertebrae, you have at the back of the vertebra these facet joints called, let's not worry about what they're called. Let's call them facet joints. And that's you have the superior articular facet, and superior means above, and articular means joint, and facet is just a flat surface or a face. And that's called that because it's the flat face at the top of the back of the vertebra. And then you have the inferior articular facet, and inferior just means below. And in between those parts, you have the pars interarticularis. Okay, and the pars interarticularis, pars means part, inter means between, and articularis means joints. So the pars interarticularis is literally the part in between those two joints. Okay, let's have a look at that on our vertebra model. Here is an L4 vertebra. Here is the superior articular facet. There is the inferior articular facet. Okay, and this here is the pars interarticularis, the part between the articulations, the joints. And so a pars interarticularis fracture is a hairline crack somewhere in this region here. All right, so pars interarticularis fracture, why do we care about that? Why is that thought to be potentially related to spondylolisthesis? Again, let's take a look at the models. And so a spondylolisthesis is a forward slippage. A listhesis means to slip. Okay, it's a forward slippage of one vertebra on the vertebra below it. Okay, so this is the L4, this is the L5, and a spondylolisthesis at L4, L5 would be this L4 sliding forwards a bit. Now, you see as I slide this forwards, I have to lift it up so that the facet joints don't prevent it from sliding forwards, right? Because it's like, well, this can't slide forwards when those facet joints are there because they prevent that movement. But if you imagine, okay, a crack here, okay, if you imagine a crack here, a fracture that allows this facet joint to kind of wiggle backwards a little. Okay. Well, can you imagine how that could allow more forward movement of that L4 if there was a crack or a fracture in that pars interarticularis on the L4? Thumbs up if you can picture that in your mind's eye, or if you can't, give me a shrug sign and look confused. Okay, great. So a pars interarticularis fracture by itself is very common and usually not associated with pain, and almost always doesn't progress to a spondylolisthesis. So lots of folk, particularly athletic people, have pars fractures, and they're not a big deal. But every so often, once in a blue moon, the cracks can progress and become a spondylolisthesis because they essentially allow that inferior facet to kind of wiggle backwards. All right, spondylolisthesis is a forward slippage of a vertebra, and here's one on an MRI, and there's another one. There are several grades of spondylolisthesis. You don't really need to memorize this because obviously it's not your job to diagnose people with a grade, and the exercise recommendations are the same regardless of the grade. So that's just like an FYI for your information. When they talk about grade 1, grade 2, grade 3, etc., that's what they're talking about. Now, the funny thing is, or the surprising thing, I guess, is that spondylolisthesis is very common, or increasingly common, I would say, is probably a better word, in pain-free people as we age. So this is a systematic review of imaging features of spinal degeneration in pain-free people from 2015 from Brinjicci et al. And what they found was they looked at a whole bunch of different imaging findings, disc degeneration, disc bulge, etc. But what they found was spondylolisthesis is pretty uncommon in pain-free 20-year-olds, but increasingly common, so that 50% of pain-free 80-year-olds have a spondylolisthesis. So it basically increases fairly significantly with age in pain-free people, which seems to suggest that it is a relatively normal, aspect of the aging process. And a different study, also from 2015 from the same group, called Findings of Disc Degeneration are More Prevalent in Adults with Low Back Pain Than in Asymptomatic Controls, a systematic review and meta-analysis. So this looked at, the previous study, this one looked at just pain-free people. Okay, so we only looked at pain-free people, and we said, okay, out of all of the pain-free people, how many of them have a spondylolisthesis? Well, it turns out, if you're 50 years old, about 1/7, about 14% of people pain-free at 50 years old have a spondylolisthesis. But that doesn't tell us whether it's more or less or the same amount of common in people with pain, right? So what about people with pain? Do more than 1 in 7 people with pain have a spondylolisthesis? Well, the answer is no. So this was a separate systematic review and meta-analysis where they looked at the incidence in people with pain, compared that to the incidence in people without pain. What they found was, quote, findings not directly related to discs such as spondylolisthesis and central canal stenosis demonstrated no association with low back pain in our study. And this was a pretty large study of several thousand people. It was a systematic review and meta-analysis of multiple studies, in fact. And so that's a reasonably robust finding. I think we can have, moderately high confidence that that's a true finding. However, there may be an association with leg pain for spondylolisthesis, and this is a more recent study from 2017. So the one I just showed you was from 2015. This one's from 2017, so it wasn't included in that previous study. And this was a study of about 3 or it might have even been 600, I think, adults. and they found that spondylolisthesis was more common in the people who had leg pain compared to the people who didn't have leg pain, but it was only slightly more common. It wasn't a lot more common. And just in case you're interested, if this is the first time you've studied with me, when I say, hey, you know, here's a fact, okay, spondylolisthesis might be associated with leg pain. Well, how do I know that? Well, I know that because here's the research paper that found it. And I know this writing here is super small and you can't possibly read it on your screen right now, but we'll provide you with the PDF version of these notes when we post the recording. In fact, I'll post you a link in the chat in a moment, and so you can look at this at your leisure. And also there, in most of these, there's a little blue link here, which in the PDF is a live hyperlink, and you can click on that and actually download that paper and read it if you want to. So basically, if I say, hey, A, B, or C is a true fact about the world, you know, there should always be what this is called a citation, which basically says, and here's how I know that. All right. So there we go. So now we're going to do a little self-test. And the purpose of the self-test is not to make you feel bad or stressed or under pressure or impress me with how much you can remember or anything. It's actually a learning part of the learning opportunity. There's really good evidence that something called practice testing is a really powerful way of improving your own recall and understanding of something. And practice testing simply says practice recalling the information. Okay, so if you want to get good at recalling the information, the best thing to do is practice recalling the information. So I would really love you to rack your brain and see what you can come up with. And I would love it if you don't know, if you just write, you know, !WTF/WTF/dunno/ I'm drawing a blank here or whatever. And if you do have a guess, just take your best guess. And if it's wrong, who cares? Okay. And in a minute, I'll tell you what the answer is, and that'll help you improve your understanding. All right. Question 1. What is low back pain? What is low back pain? If you're on a phone, I know it's difficult to switch between the chat screen and the viewing screen, so just keep the chat screen open and I'll read out the questions for you. If you're doing this as a recording, please participate as well. Don't just be a passive recipient, because I already know this stuff, so I don't need to practice it. You need to practice it, so practice it. All right, so type it into the chat, please, and I would love it if you typed it in, you know, two-finger typing, typos, spelling mistakes, poor grammar, all good, just as long as it basically communicates the general gist. What is low back pain? And the definition, according to the ACSM, is low back pain is pain, muscle tension or stiffness, localized below the rib margin and above the inferior gluteal fold, with or without leg pain. All right, next question. What is spondylosis? And the answer is it's an umbrella term that just means there's stuff going on in your back. There's a problem in the back, is basically what it means. What is pars interarticularis fracture? Otherwise known as a pars defect, otherwise known as a spondylolisthesis. And the answer is it is a hairline fracture in between the superior and inferior facet joints in the pars interarticularis. What is spondylolisthesis? And the answer is spondylolisthesis is a forward slippage of one vertebra relative to the one below it. Does spondylolisthesis cause back pain? The answer is, doesn't seem to cause pain in the back. Does it cause sciatica, or otherwise known as leg pain? And the answer is, yeah, it probably has something to do with leg pain. I would say, and we'll find out in a moment, that probably cause is probably not the right word, but it does seem to have an association with leg pain, and it's one of the factors that contributes to leg pain. All right, so now we're going to talk about leg pain. So the reason I want to shift to talking about leg pain rather than talk about spondylolisthesis for the whole hour is because if we're concerned about what do I do for someone with spondylolisthesis, well, we're concerned about it presumably because it causes some kind of problem, right? I mean, it's like you don't ask, if I put on a workshop that says like how to give Pilates to people with red hair, you'd be like, well, what the fuck, just give them regular Pilates like everybody else, right? Who cares what color their hair is? And so probably the only reason you care about spondylolisthesis is because, for some people it may cause a problem, right? So we want to know, if the problem that spondylolisthesis can cause is leg pain, okay, well, isn't the better question, how do we help people with leg pain rather than how do we help people with spondylolisthesis, right? Because leg pain is actually the issue, because there are a lot of people with spondylolisthesis with no symptoms, they're totally fine, they just rock their life, do everything, no problems. Like, well, for them, we don't have to do anything. Just treat them like people with red hair, okay? Whereas for people with spondylolisthesis who have leg pain, well, the problem is the leg pain. So let's see what we can do about the leg pain. All right. Well, it turns out that sciatica, aka also known as leg pain, okay, that comes from the back, is not a straightforward thing. It's complex and multifactorial, and it's often related to whole person factors, not just a bit of something pressing on a nerve in the back, although that can be part of it. All right, so sciatica is complex and multifactorial. Inflammation is pretty much required. If you want to have sciatica, you've got to have some kind of inflammation. And you can have peripheral or central sensitization of the nervous system. We're going to spend a minute talking about what that is. Psychosocial factors are also important, and so those are things related to your thoughts and feelings, psycho, and your context and the meaning, social. And nerve compression in the back can contribute to sciatica or leg pain, but it's not enough by itself to cause leg pain. So you can have nerve compression without leg pain. All right, so mechanical compression of the nerve root is not the main factor in sciatica. And there's pretty good evidence that pressure on a nerve is not enough to cause symptoms, that you also need to have inflammation present. So you can have pressure on a nerve and be completely, fully functional, no pain, everything works perfect. In fact, about a quarter of pain-free, symptom-free people have spinal cord compression on MRI, right? Which is awesome, because that says that the spinal cord has a lot of margin for error built in, right? You can have a quarter of, you can have a quarter of the population with compression and it still works perfect. So that says it's very robust and it's not, doesn't get easily discombobulated. So inflammation is probably the only ingredient that is 100% required if you want to have leg pain, sciatica. And inflammation can increase or can cause pressure on the nerve root even if there's no physical things touching the nerve root. And that is because your spinal cord passes through this spinal canal here behind the vertebra, okay? And that essentially is a tube of bone. And that tube of bone is filled with, 100,000 spinal nerves, surrounded by and bathed in cerebrospinal fluid, which is the same fluid that's inside your skull. Okay, and it's essentially water with a bunch of proteins and sugar and some minerals and things floating around in it. It's basically 99% water. Okay, so it's basically your spinal cord is 100,000 nerves within this bone tube bathed in water. And now the bone tube actually is pretty much watertight. It's got, ligaments and things that sort of keep everything in. So the water doesn't move freely in and out because you've got cerebrospinal fluid only inside your brain and spinal cord, not floating around the rest of your body. And so if you have inflammation inside that neural canal, right? So just you've got ligaments in there, the posterior longitudinal ligament, the ligamentum flavum in there. You've got some discs, sort of within that canal. You've got all kinds of stuff in there, right? You've got nerves. So just let me wave a magic wand and cause some kind of inflammation in there for whatever reason, okay? Well, when you have an inflamed body part, it swells up, right? You've caught your finger in the cutlery drawer before, it gets swollen. Well, it gets swollen because fluid is attracted to that inflamed area, right? It draws fluid, right? So just imagine you're inside that spinal canal, that rigid tube of bone, you get more fluid in there, right? So what happens if we put a closed tube of bone there with full of water, and then we put more water in it? What happens to the pressure inside there? Goes up, doesn't it? Right? So now we've got a nerve tract in there with more pressure. Now, even if we did an MRI, we'd go, oh, there's no disc touching the nerve, nothing's touching the nerve, but how come you're getting this leg pain? Well, maybe it's just the increased, what's called hydrostatic pressure, the pressure of the fluid in there that might be compressing the nerve enough to cause that leg pain. So does that kind of make sense to you? All right, so inflammation is really crucial if you want to have leg pain. Compression by a disc or a whatever is optional. You don't have to have that. Now, inflammation can cause leg pain and contribute to leg pain not just by increasing the pressure, but actually increases the sensitivity of the pain system as well. Okay, now you've experienced this, I'm sure, in your life. If hands up, who's ever been sunburned? Okay, well, what happens? When you're sunburned, the tissues that are burned become sensitive. Right, so things that normally wouldn't hurt, like warm water or someone slapping you on the shoulder or scraping against a rough bit of clothing or whatever. Like your pain system becomes more sensitive, so things that don't normally hurt, and things that would normally hurt more. Okay, and that is a property of the pain system, basically amplifying its signal, and so inflammation causes the local tissues. So if you've got inflammation in your finger becomes more sensitive. You've got inflammation in your spine becomes more sensitive. Okay, and then there's something called central sensitization. And that is neurons in your brain and spinal cord. So neurons are nerve cells. Okay, and with central sensitization, it's brain and spinal cord that becomes more primed and fires more easily. And so rather than, the nerves in, say, your upper back where you're sunburned becoming more, sensitive to these pain experience, it's the nerves in your brain and spinal cord. Now think about when it's the nerves in your brain and spinal cord, they control your whole body, right? So you can get increased pain sensitivity any and everywhere. Right, so if your brain is more sensitive to pain, you can get more pain anywhere your brain wants. In your liver, in your little toe, in your fingers, in your eyeballs, like wherever. Okay. Whereas if it's the skin of your upper back, the nerves in that region that are sensitized, they can only cause increased pain sensitivity in the skin of your upper back. Right. So if we somehow manage to sensitize or increase the sensitivity of pain of your central nervous system, you can get pain in weird ass places and many places all at the same time. All right. So when you get central sensitization, it's there's lots of physiology that happens. So physiology is like stuff that cells do. Okay, so we get increased firing rate of your spinal nerves. We get increased responsiveness of nerves to mechanical stimuli. So something that would normally, cause a very small nerve signal causes a very big nerve signal. So something that you would normally perceive as a very gentle touch gets perceived as, harmful. Okay. Lower threshold of excitation by non-noxious inputs. So we have nerves that are called nociceptors, okay, and they detect big sensory inputs. So if they're stimulated, so you've got certain nerve endings, for example, that detect temperature, right? And then other nerve endings that detect pressure, and other nerve endings that detect vibration. Okay, and so the nerve endings that detect, say, temperature, they can tell you if, you put your hand in some lukewarm water, they can tell you that water's a little bit warmer than your, body temperature, or a little bit colder than your body temperature. And then you have nociceptors, and they are kind of like your, in case of emergency, break glass nerve endings. So they are only activated if the water's really hot or really cold. Okay, so basically the nociceptive nerve endings only, generate a signal if you put your hand in, water that is potentially hot or cold enough to damage your hand, right? So when you have central sensitization or even peripheral sensitization, those nociceptive nerve endings become more easily stimulated. So when you put your hand in a cup of lukewarm water, they can send a signal to your brain going, oh my God, the water's so hot, watch out, it's an emergency, take your hand out of that terribly hot water, you might die. Okay. So they become stimulated by non-noxious or, non-harmful inputs. And also you can have, within central sensitization, immune attack on spinal nerve tissue, which doesn't sound like a good policy. Okay. And that can also contribute to weird, crazy sensations and things happening down the leg, which is where some of those spinal nerves go. And your neurons can just start firing when there's no stimulus, right? So they're sitting there doing nothing, twiddling their thumbs, and all of a sudden, hey, let's send some signals to the brain for no good reason, right? So they can just start firing. So what causes central sensitization? Well, there's genetic component. Some people seem to be more predisposed. Psychosocial stressors, so thoughts, emotions, human relationships, social context, the meaning you make out of things, and neuroimmune system changes, including inflammation. So all of these things contribute to central sensitization. And psychosocial factors, in fact, predict long-term outcomes in sciatica. So these are things like poor mental health, poor coping skills, just reliance on passive coping strategies like taking medications or getting other people to massage you or whatever, rather than having active strategies like stretching or walking or meditating or whatever. It's like having negative pain beliefs. So the belief that pain indicates damage is associated with worse outcomes and more central sensitization. Expectation of poor outcome is associated with poor outcome, okay, because you become kind of, well, if you think like, well, what's the point? It's probably going to turn out for the worst, so why bother trying, okay? In fact, it's crazy that depression is associated with increased systemic inflammation, right? So we're not, like, I want to try and communicate here that when we say psychosocial factors, I don't for a second mean, oh, you're imagining it, you're making it up, you're malingering, and none of that. That's not what I'm saying. When you have an emotion or a thought, there's physiology that happens in your brain. Electrical signals, chemicals, things happen in your brain when you have thoughts, emotions, etc. Okay, and that physiology, the actual physiology, can affect the rest of your body. So, okay, when you're depressed, you release more, you make more pro-inflammatory proteins, and they circulate through your system. Okay, and pro-inflammatory proteins circulating through your spine can increase the sensitivity of the pain system, right? So it's not just like, hey, you're imagining it, making it up, it's psychological. yes, it's psychological and it's also physiological, right? So all of these things, there's a physiological mechanism that underpins that psychological factor. All right. So bottom line is it's really freaking complicated. Okay. It's not just, poke a nerve in the back with some, bit of ligament or disc or whatever, and therefore sciatica, right? There's lots and lots of shit that goes on that determines why one particular person has sciatica on a given day and someone else doesn't. So sciatica is caused, in summary, by a combination of inflammation, nerve root compression, so something pressing on a nerve, whether it's the inflammation itself or whether it's, something else pressing on a nerve, peripheral and or central sensitization, psychosocial factors, and nerve compression alone is not enough to cause sciatica. So that is why when we see spondylolisthesis and you picture, here's the nerve canal, the neural canal, this is where your spinal cord goes through, through the neural canal. If you picture, this vertebra going forwards like that, well, can you see, if I can line this up, there's the neural canal with the vertebrae lined up, but if I slide this one forwards, can you see that the neural canal gets smaller? So you can see that, the thing that we would be most concerned about with spondylolisthesis would be narrowing of the neural canal, which could cause compression on the spinal nerves, which could cause sciatica. And so what we now know is that, yes, that's a thing, but it's not enough to cause a problem, because 25% of pain-free people are walking around right now, statistically a quarter of you guys have spinal cord compression right now. I don't know about it because it's not causing any kind of problem for you, And so compression on this, so when we look at a scan and we go, oh, there's compression on the nerve, that doesn't tell us whether that person's got pain. So why do some people get pain and why do some people not? Well, it depends on their inflammation, their mental health, their stress, their coping strategies, their beliefs, their social support, all of these other things, which collectively, contribute to whether their pain system tells them, watch out, there's an emergency in your leg or not. All right, self-test. What causes sciatica? And if your answer is lots of stuff, probably including some combination of inflammation, psychosocial factors, pressure on a nerve root, central and peripheral sensitization, or in other words, it's really freaking complicated, that is the correct answer. Is compression of a nerve root sufficient to cause sciatica? And the answer is no, it's not. What are some of the structural actually leave that one because that shouldn't be in there. What is central sensitization? Again, that's a really big question, and we've spent 3 minutes talking about it. So just give me your best current understanding of what is central sensitization. And the answer is, in central sensitization, nerve cells in your brain and spinal cord become primed to fire more easily and more frequently, and so you can experience more pain. You become more sensitive to painful things, and things that are normally not painful can become painful, and that can affect any part of your body. What contributes to central sensitization? Again, we spent a couple of minutes on this. This could be a 1-year course just on central sensitization. So don't worry if your answer's like, not very precise, but just give me the best you got. And the answer is heaps of stuff, probably including genetics, inflammation, psychosocial factors, and, other stuff. All right. Surgery and all forms of exercise seem to work equally well. So the natural history is this: if we do nothing, right? If we just let people go on their merry way, so we have somebody who's got, spondylolisthesis, nerve root compression, and leg pain, okay? Well, more nerve root compression predicts better outcomes a year later because the body heals often. Okay, and that's regardless of whether they have surgery, no surgery, exercise, no exercise. And even moderate to severe motor deficit. So this is people who can't contract their quad muscle or can't, use their calf muscle properly or whatever. They've got weakness in one of the legs because of, loss of nerve signal because there's nerve compression. Most people recover fully within a year. Okay, so the body can heal. And for sciatic with spondylolisthesis, surgery is better than exercise, but not enough that it makes a difference. So this is a systematic review and meta-analysis of surgery or physical activity in the management of sciatica from 2016. And they found that compared to exercise, people who had surgery were 17 to 25 points out of 100 better off than if they just did exercise. And this is on a visual analog scale. This is like a pain scale. So this is where we come to something called the minimum clinically important difference, which is basically the smallest change that patients identify as meaningful. Like, I don't know, if you came to me and you had low back pain, I said, how bad your low back pain? You're like, it's a 6.5 out of 10. And I said, okay, well, if you come and work with me for 12 months, I'll get it down to a 6.4 out of 10. Would you consider that a meaningful difference? You'd probably think, no, no, I wouldn't pay for that. Okay. Would you have spinal surgery for that? And, probably most of you would say no, right? And so but if I said, okay, if I could get it down to a 6 out of 10, a 5 out of 10, a 4 out of 10, a 3 out of 10, what would be the minimum difference that you would consider oh yeah, that'd be meaningful. I'd notice that, okay? And it turns out that the minimum clinically important difference on average is something like 18 to 40 points, right? So some people reckon, if we could go from 6.5 out of 10 to about, 4.8 out of 10 or something like that, okay? 4.7 out of 10, that would be meaningful, okay? Other people, they think we'd have to go from a 6.5 out of 10 to a 2.5 out of 10 for that to be meaningful, right? And by meaningful, I don't mean worth it. I mean can notice the difference, right? Can you notice it? If you stood, and had your loved one, put a finger on your back and then put another finger on your back, in a different location, right? If they're this far apart, you can probably tell the difference, right? If they're this far apart, you can probably tell the difference. But when they get close enough together, you can't actually tell the difference between which one's which, right? So how far apart do they have to be before you can actually tell that there are 2 pressure points rather than 1, right? And that's equivalent to this. How much would I have to reduce your pain, okay, before you noticed that it had reduced? Okay, and the answer is somewhere between 1.8 out of 10 and 4 out of 10 for most people, okay? Most people can't detect a difference of less than 1.8 out of 10. Or 18 out of 100. So here's what we say, this is 18 out of 100 there. Okay, so less than that, no one can detect the difference. Whoops. Here is 40 out of 100. Above that, everybody can detect the difference. Okay, and here is this range here, 18 to 40, where, okay, some people can detect this, but not others. A fair number of people can detect this, and just about everyone can detect this amount of difference. Okay, and this is no pain at all, and this is the worst pain imaginable. Okay, well, here's how much surgery helps people with spondylolisthesis. Right, and that's not a lot, right? That's a pretty underwhelming effect for spinal surgery, which has pretty major potential risks. Right. And there's no difference at all between exercise and surgery for motor deficits. So if you've got like weakness in your quads, weakness in your tibialis anterior, whatever, surgery is no better than exercise, because guess what? Most people get better with exercise, right? So surgery doesn't enhance that at all. And even for high-grade spondylolisthesis, so remember we said that there are 4 grades, and grade 3 and 4, where there's like a 50% slippage. Okay, even for high-grade spondylolisthesis, surgery and exercise give the same results. And within exercise, okay, if we think about what sort of exercise do we do? Well, stabilization exercise, where we, in neutral spine and gently recruiting transversus abdominis without the obliques, and gently recruiting the multifidus muscle and maintaining the L4 still relative to the L5 when we lift our detailed things. Or if we just go, hey, let's do some push-ups and some sit-ups and some squats and some lunges, we get the same benefit. Everyone gets a benefit, right? So stabilization exercises help. Push-ups and sit-ups and lunges help. They all help equally. In fact, no form of exercise has been shown to be superior. And this is a relatively old study from 2003, a systematic review of physiotherapy for spondylolysis and spondylolisthesis. And that's the most recent systematic review of exercise that we have on this topic. All right, self-test. What happens to sciatica if we do nothing? That's called the natural history. What happens if we do nothing? And the answer is, for most people, 4 out of 5, it gets better all by itself. How does surgery compare to exercise? The answer is, for motor deficits and severe, like high-grade spondies, it's no different. And for low-grade spondies, it's very slightly different, and it's right on the border of the minimum clinically important difference. So does that mean surgery is bad and you shouldn't get it? No. I think, just say you had terrible, pain that had not responded to exercise, and you would be happy with the 1.8 out of 10 improvement. Okay. Well, yeah, consider surgery. But I reckon you should definitely try exercise, give exercise a red hot go first before you try surgery. Is stabilization exercise or general exercise more effective for spondylolisthesis? The answer is they're both equally effective. True or false? One form of exercise has been shown to be superior for spondylolisthesis. And the answer is false. All right, here we get to what we do for these people. Guideline-care, and it's just reassurance and advice to stay active. So back to the ACSM's guidelines. And here is page 172. Current literature does not support a definitive cause for initial bouts of low back pain. Okay, so somebody has back pain and then they get a scan that shows they've got spondylolisthesis. We can't actually determine whether that spondylolisthesis is the cause of their pain or not, right? Because there's lots of people with that same exact scan finding who don't have back pain. So how do we know if that's causing the pain? Well, we don't. And that's why they say here that current literature does not support a definitive cause for initial bouts of low back pain. The best available evidence, this is all from the ACSM guides, the best available evidence supports a classification approach that de-emphasizes, the importance of identifying specific anatomical lesions. That just means like some kind of injury, a lesion, after red flag screening is completed. So remember red flags with those things: cancer, equina syndrome, ankylosing spondylitis, things like that. So we need to rule out those things. But those are the quote specific causes of low back pain. But once we've ruled out those red flags, the best available evidence supports a classification approach that de-emphasizes the importance of identifying specific anatomical lesions. So don't talk about the spondylolisthesis, just talk about the symptoms and the function, because that's what people are interested in. And that's the evidence that we have suggests that's more effective. Current guidelines for the management of low back pain consistently recommend staying physically active. When recommendations, so this is exercise prescription, when recommendations for exercise are provided, they should follow very closely with the recommendations for the general population. Special consideration. However, there is insufficient evidence for any benefit of emphasizing single dimension therapies such as abdominal strengthening. Individual response to back pain symptoms can be improved by providing assurance and encouraging activity. Because remember those psychosocial factors like mental health, negative expectation, negative pain beliefs, passive coping strategies, all those things. Reassurance. There is a lack of agreement on the definition, components, and assessment techniques related to core stability, right? There's a lack of agreement on the definition. We don't agree on what it is. We don't agree on what the components of core stability is, and we don't agree on how to assess core stability. So in other words, this, if I translate into less formal language, it says, what the fuck is core stability? Right? There's a lack of agreement on the definition, components, and assessment techniques related to core stability. Furthermore, the majority of tests used to assess core stability have not demonstrated validity. So should you strengthen your abs? Yes. Should you focus on only strengthening the abs? No. Should you practice your balance and holding your torso still whilst you move your legs? Sure. Should you focus only on doing that? No. It's just one component of, strengthening, stretching, and doing all the good things that we do. Repeated movements and exercises such as prone press-ups or knees to chest that promote centralisation, i.e. a reduction of pain in the lower limb, are encouraged to reduce symptoms in patients with acute low back pain with related lower extremity pain. So if somebody has leg symptoms, sciatica, leg pain, sometimes repeated kind of swan dive / cobra movement can alleviate the leg pain. For other people, it's repeated forward bending that alleviates the leg pain. And there's not necessarily a rhyme or reason about who benefits from forward bending and who benefits from back bending. And the best way to find out is, one, ask your client, hey, have you found that forward bending or back bending alleviates your symptoms at all? And if they're like, oh yeah, forward bending feels great, let's do some of that. And if they're not sure, we'll just try 15, 20 back bends, then ask them, hey, how's your leg feeling right now? Better, worse, or same? If it's better, great. Anytime you get leg symptoms, do some back bends, that'll alleviate it. If it's not better, try forward bends. Let's try 15 or 20 forward bends. How's your leg feeling right now? Better, worse, or same? If it's better, great. Anytime you get leg symptoms, let's do some forward bends. Now, you're not going to fix anything by doing this, but it can temporarily alleviate symptoms, so that can be a good thing. People like to have their symptoms alleviated. And there's no particular rhyme or reason about, whether it's going to be forward bending or back bending for any particular person that's going to alleviate those symptoms. Exercises such as yoga and Pilates have shown to be effective interventions for low back pain. However, the research is not clear on whether any single intervention is superior to another. Therefore, the choice of exercise should be fundamentally driven by client preference and practitioner expertise. So in other words, what the client enjoys and you know how to do, that's what you should do. Do that. All right, so if we sum all of that up, the Guideline-care, it says reassurance and advice to stay active. Okay, get moving however you like, however you know, okay, and try not to worry about it. All right, self-test. True or false? Current evidence supports a definitive cause for low back pain. And the answer is false. True or false? Guidelines recommend de-emphasising the importance of identifying specific anatomical lesions after red flag screening. Or in other words, work with the whole person, not just the spondylolisthesis. What do guidelines recommend? And the answer is reassurance and advice to stay active. And how do you stay active? Do something you enjoy and that your instructor knows how to help you with. So whatever form of exercise that is, and I guess for most of us that's going to be Pilates, right? But it doesn't have to be any particular movement or technique or muscles, or it can just be like footwork on the reformer, leg pull on the mat, hundreds on the Cadillac, push throughs, back bends, forward bends, twists, neutral spine, leg work, arm work, back work, front work, side work, whatever the client enjoys, and you have the equipment, knowledge and whatever to provide for them, that's what to do for them. Okay, with the one little asterisk that if they have leg symptoms, try repeated back bending. And then after they finish the repeated back bending, ask, are the leg symptoms better, worse or same? If it's better, do more of that. If it's not better, leave it. If it's worse, do less of it. If it's not better, try forward bending, 15 or 20 forward bends. After that, how's your leg pain? Better, worse or same? If it's better, great, do more of that. If it's worse, do less of that. If it's neither better nor worse, do it if you want to do it. Don't do it if you don't want to do it. So that is what I have for you. We said that spondylolisthesis is not a specific cause of back pain, using specific in that very advised context in reference to the guidelines. Sciatica is complex and multifactorial as shit, and often related to whole person factors like mental health, systemic inflammation, central sensitization. Surgery and all forms of exercise seem to work equally well, which is awesome because it really doesn't matter what you do. As long as you do something, they're very likely going to get better. And Guideline-care is reassurance and advice to stay active. All right, that's all I had. I can't believe we got through that in only 63 minutes. Congratulations for following along to whatever extent you were able. And I did, pack in, I think, a little bit too much. So if you're feeling like you've shoved a lot of stuff inside your brain and it's leaking out the edges, that's probably normal. Okay, and the purpose of today is not for you to memorise every single slide and know all those factoids, but I hope what you take away is that spondylolisthesis is not a specific cause of pain, and for a lot of people it's just not a problem whatsoever and you can completely disregard it. And for other people who have spondylolisthesis and leg pain, it may or may not be related to the spondylolisthesis, and if it is related to spondylolisthesis, you can probably help them get over it, okay? Even though you're not going to fix the spondylolisthesis or change the spondylolisthesis, you can probably help them get rid of the leg pain and get back to doing the things they love doing, okay, and to moving fearlessly and doing Pilates and gardening and riding their bike and swimming and mountain climbing and doing all those things, okay, by just reassuring them and encouraging them to keep moving, okay? It really is that simple. All right. If you've got any questions or comments or thoughts or anything.
Are you putting the link, Ralph, in the chat for the PDF?
Oh, yeah. Thank you very much. Thank you for reminding me.
I'll put that in. Thank you for that.
Yeah.
I have a spondy, so I know. I always watch these things to make sure I'm managing it properly. As you get older, you worry more.
Yeah, no, worry less. That's my advice.
I think
Yeah,
the main thing for me is keeping my height so that I know that that spinal column has as much space in there as it can. I've
yeah,
had sciatica before, just one episode. And after that, I became a personal trainer and a Pilates instructor after having the sciatica because it gave me a scare.
great. Well, great response, Carol. That's awesome. More active, better. That's fantastic.
Thank you.
Can I just ask a quick question, please? I'm spondy as well, and I'm just wondering. I've always been told to avoid loaded rotation and extension of the lumbar. So, and I'm generally moving a lot. Definitely helps me more than not moving. But I just wondered what you think about the whole loaded rotation thing.
I would just 100, so in regards to extension, rotation, whatever movement, I would just be guided by symptoms. Okay, so if you do say, a loaded extension or rotation movement, I don't know, maybe you're doing, thread the needle stretch, we kind of this one, maybe doing that on the Cadillac, maybe, whatever you're doing, okay, twist on the reformer with the side arm series, whatever. If that doesn't worsen your leg symptoms, fine, do it all day, right? If you do 3 thread the needle stretches and now you can't feel your right foot, I would say do less of it,
Yeah,
that would be the
I've
same
always
for
had
people
that
with
as well.
extension.
Avoid the rotation and hyperextension, but I mean, it doesn't really do anything to me.
And the rationale for avoiding extension is that in spinal extension, it reduces the space within the spinal canal and the neural foramen. Okay. So if we see, here is the neural foramen. Okay. This is where the nerve root exits the spinal canal and goes down to your leg or wherever. And so you can see in flexion, the neural foramen opens up. There's more space. And in extension, it narrows, so there's less space. So if for whatever reason, including a spondy, okay, or including a disc bulge or whatever, okay, disc degeneration, for whatever reason, there's less space there already for some reason, okay, if you extend, you reduce that further. So in principle, extension would be expected to be a problem for some people. But like we've seen, a quarter of the pain-free population have spinal compression and no pain whatsoever, no symptoms whatsoever. So there's a lot of robustness, there's a lot of headroom, there's a lot of tolerance in the spine, okay? And so the reason we would avoid extension is because it could potentially worsen symptoms, right? So if it doesn't worsen symptoms, there's no need to avoid it, right? And the only way to know if it worsens symptoms is do it and see if the symptoms get worse, right? And if they get worse, stop doing it, wait a bit, the symptoms will subside, okay? And just go, okay, great, now I know, don't do that particular thing, okay? Now, it doesn't mean never do any spinal extension. It just means like, okay, if you did like 20 swan dives and now your leg's hurting more, well, don't do 20 swan dives. But maybe cat-cow is fine, okay? Maybe gentle things are fine for you. So you just have to experiment and find where that line is for you. And it might vary across time because things like your mental health, your stress, your systemic inflammation, all of these things will also vary across time, right? So it might be fine one week and not fine another occasion and then fine again a few weeks later, right? So it's just going to be a dynamic experiment, and I'm sure you'll get to know, if you don't already, where your limits are. But if it doesn't aggravate your symptoms, there's no reason to avoid any movement.
Ralph,
Yeah, it's very good. The trouble that you have once you tell, if you're going to another professional, once you tell them you have like a spondy or something, they start to treat you like an 80-year-old. So
Right,
that was
right,
part of the reason.
right.
I started
And
to-
so,
yeah.
and I had this experience too. When I was starting out as an instructor, when I had a client in class who had a spondylolisthesis, I'd be like, oh, don't extend.
Oh my
Let's make sure we
God.
keep you neutral. Let's put a bolster under your tummy when you're lying prone and all of these things.
Yeah.
And what does that do? That communicates fear.
Yeah,
And
well, they just don't go
anxiety to that
back to you
person.
because who's going to waste their money to do what you'd give you? My mom's 98. I could give her the exercises some people have given
Well,
me.
you're
Please, I
very
want the next
empowered,
one.
Carol. You're very empowered, and so you've just chosen a different, option
Yeah.
for yourself. But some people aren't as empowered, and
Oh, I
they can
know.
become infected by that fear and anxiety.
Yes.
Okay. And remember, the guideline says reassurance, right? Making people anxious is the exact opposite of reassurance, right?
Yeah, no, that's good.
So
Yeah, great
we
presentation.
really, I think the first thing for you is for you guys to become as fearless as possible yourself about this, and know that if somebody's leg symptoms are aggravated by a movement, we need to respect that. Okay, but it's not a disaster. It's not a medical emergency. It's just like, okay, we poked the bear a bit and now the bear's a bit irritated. Okay, so we better not poke the bear for a bit. Okay, and the bear will settle down and go back to sleep and it'll all be good. And maybe we just don't poke that particular way, from now. But it doesn't mean never do any extension or never do any rotation. It's like just find where your limits are. Find where your limits are. And if your limits are like there's no limit, great. Just do everything.
Raphael, I have a question or a comment. Can you hear me?
Yes.
Okay, good. I 100% agreed on base the exercise based on the symptoms of the person, but I just have to question if there is not a risk of the shifting forward of the vertebra if it's expected to shift even more, and in the timeline if it's going to cause I don't know, more symptoms if it is expected to cause symptoms, because as we already know, for this percentage of the people, it will not show any symptoms at all. But I don't know if once that it progressed, once that it happens to shifting, if it's expected to progress and shift even further.
Yeah, great question. Great question. Marcella, right?
Yeah.
Yeah. So, doing extension, may not aggravate someone's symptoms, but might it cause the spondylolisthesis to progress? Is the question, right? And if it does progress, could that cause symptoms?
Yeah, because I have the same thought in the rotation, because if it one of the facets that is getting the fracture and provoking the shifting forward, and if you are doing like the rotation, so let's say that part of the facet that gets fractured, if we are promoting the rotation to that side, if we are just, I don't know, facilitating that it progress, the spondylolisthesis.
Great question. All right, so we talked about pars fracture as sometimes leading to spondylolisthesis. There's also very commonly what's called just degenerative spondylolisthesis, where it's not related to a fracture. It just kind of gradually happens for reasons unknown over time, and that I think are the majority of cases. So in the majority of people, it's not related to a fracture. It's just like similar to maybe a disc degeneration or a disc bulge or whatever. It's kind of part of aging. So if there was an athlete who had a pars fracture, and when I learned that they had a pars fracture, I would first try managing their load. Okay, and so it's possible that a pars fracture in an athlete could be basically a stress fracture. Okay, so repetitive loading beyond their body's capacity to repair. And you might find that in gymnasts, you might find it in, runners, people who repetitively, weightlifters, people who repetitively load their spine, either in extension or with a lot of impact or whatever. If they do a lot of training and maybe not enough nutrition, like with gymnasts are in a weight category sport, so they're always on a diet, so they're not getting enough calcium, not getting enough protein, not getting enough calories, so that can predisposed to stress fractures. So if I
What
had an athlete
about
who
what about osteoporosis?
about
What about if it increased the risk of getting that type of fracture?
sorry, I don't quite understand the question.
Yeah, you were talking about the nutrition, and if it was a repetitive load that might increase the risk of getting that fracture in athletes. But then I was just thinking if the bone density will, I don't know, make any influence on half the people on a risk of getting that type of fracture.
Yeah, so there is something called the female athlete triad, which is disordered eating, low bone density, and amenorrhea, with like stopping periods, and they can predispose to stress fractures. Typically, female athletes in weight category sports, where they're limited in what they eat, so they don't have enough nutrition, so their bone density decreases. Also, when the period stops because they're not eating enough, that reduces their estrogen, which further reduces bone density. So it's a pretty serious situation. But even just for regular folks who don't have disordered eating, who, whatever, but they just have a stress fracture in their pars interarticularis because they just push their body to the limit, over an extended period of time. Well, the first thing I would do is I would address training load. So I would reduce the number of training sessions and the intensity of the training sessions and give that tissue a time to recuperate, and it's a fracture, so I would think like weeks or a couple of months would be, that's how long a fracture takes to heal typically, But you need to give it the opportunity to heal by reducing the load on it and having adequate nutrition, calcium, calories, all of that, in order for that to happen. After I did that, I would gradually increase the training load again, back up to the normal training load. And I think if that was a stress fracture, that would, pretty much solve for that. So if it was related to the activities that they're doing, yes, the first thing I would do would be modify the activities, but it's usually related to the amount of training that people are doing, not just whether they're doing a back bend or not. And then also nutrition, obviously, and recuperation, recovery are very important. If you have somebody with, so that's for pars fracture, right? So if I had someone with a pars fracture, if they're an athlete, I would suspect it could possibly be like a repetitive strain injury, a stress fracture. So I would just reduce the amount of strain on the system, give that part an opportunity to recover. And you might have a lot of pushback from the athlete because they might have to miss competition and reduce their performance and stuff. So that's going to be a whole negotiation that you might have to do with people. I haven't included the study in today's presentation, but there is a study that looked at, do spondylolisthesis tend to progress? And the answer is not really. So they when they look at them in kids, they tend to progress like at, during growth, but then the progression slows down quite significantly. And basically, I think from midlife on, they basically don't progress. That seems to be what this study found anyway. And it doesn't seem to be related to whether people exercise or not or whatever. It's just like, probably mostly genetic. Okay. So again, I wouldn't worry about, would back bending or rotation or whatever, make the spondy worse, except, for an athlete who had a newly diagnosed pars fracture, I would modify their training load and give it an opportunity to heal. And I would be respectful of symptoms. And if there was a movement that was aggravating someone's symptoms, I would take that movement out of their workout.
Okay. Thank you.
So sorry, that was a very long answer, but it was a very good question.
I appreciate those. Thank you.
Hi, I have a question.
Please.
So I have a spondy in my L5, L4, L5S1, but the main problem is my L5S1, and mine's degenerative. So it does cause a lot of problems. So maybe it's like the symptomatic that we're talking about, centralized pain that it's causing. But also, my chiro keeps on saying that I have thoracic spine pain, and it's caused because of my spondy. Is that What do you think about that?
Well, I've got two answers, and one is no, I don't agree with it. And the slightly more detailed one is it's possible, but probably not for the reasons that I imagine your chiropractor might have said. So, we just read the ACSM guidelines that said current evidence doesn't support a definitive cause for back pain. And in the vast majority of cases, and once we can rule out things like cancer and fracture and things like that, we really can't see what we see on a scan doesn't tell us about pain. You can't see pain on a scan. So you can see disc bulges, you can see degeneration, you can see arthritis, you can see spondies, you can see all kinds of things on a scan. But then we can see all those same things on scans of people who are pain-free. So we just don't have the technology to identify what's causing pain. Does a spondy, is there a mechanical reason why a spondy would cause thoracic pain? Well, there may be, but we certainly don't have the technology or the understanding to identify that at the moment. And so I believe that anybody who claims, and I'm not saying this is what your chiropractor's saying because all I've got is what you just told me, but if anybody who claims that, mechanically this spondy is causing pain anywhere is exceeding the current level of knowledge. They're basically just making shit up. So that's my first answer is no, I disagree. The second answer is yes, it's possible, but not for the reasons probably that I imagine your chiropractor might have told you. And that is because a spondylolisthesis could be a factor in creating some kind of central sensitization, right? So if you have a spondylolisthesis, there might be some localized inflammation, which might sensitize your spinal nerves, turn up the pain volume knob, as it were, which could, because the spinal cord, along with the brain, controls sensation everywhere in your body, right? So if you were just a brain and a spinal cord in a vat, with no actual body, you could still have thoracic pain. You could still have leg pain. You could still have, a sore tummy, right? Because the nerves that tell you you've got, a sore tummy are in your brain and spinal cord. So you can have a problem in your spinal cord that causes pain literally anywhere in your body. So, but not because it's like mechanical, A pressing on B, pressing on C, therefore pain. It's more probably, if it is, related to central sensitization, where you might go, okay, the spinal nerves become inflamed, so they become more sensitive. So now things that are normally not enough to cause pain, like a bit of stiffness in your thoracic spine, for example, now are perceived as painful because you've turned up the pain knob. And so I would expect that to also manifest potentially in other places, like maybe you've got shoulder pain, maybe you've got digestive tract symptoms. Maybe you get headaches and eczema and sleep disturbances and diarrhea, and all of these symptoms are correlated with central sensitization.
So then what I get from what you're saying is that my centralization pain is basically like an amplifier for other symptoms happening. So like, for example, my thoracic spine pain, if it's like at a level 2, based off of my injury in the back, then it's amplifying it to like a level 5.
Yeah, basically. But even, I think it might be a level 0, right? And just need like, I think the best metaphor is the cup of resilience. Okay. And the cup of resilience just says that, and obviously this is not an accurate explanation of the physiology of how pain neurobiology works in your body, right? But I think it's a really useful metaphor that helps us think in useful ways about what causes pain. Right. So imagine you've got a cup of, we call it the cup of resilience, and the cup represents your ability to absorb and tolerate stress. Okay. And stress in this context is just anything that threatens to disturb your homeostasis, your dynamic balance. So stress could be hot temperatures, cold temperatures. It could be changes in your acid-base balance within your body. It could be changes in your blood glucose or chemicals or inflammation. It could be mental stress, it could be financial stress, it could be worry, it could be poor mental health. All of these things are stressors. And the reason we use this cup of resilience metaphor, because all stressor, like when you have a stressor, say something that threatens to disturb your homeostasis, okay, you respond to that by releasing the same stress hormones, cortisol, adrenaline, noradrenaline, these types of things from your adrenal glands above your kidneys. Okay, so if you're in a really hot environment, okay, well, that's a stressor, right? Because your body likes to maintain a constant temperature. So you release cortisol, adrenaline, etc. And in response to those hormones, a bunch of things are triggered. You start sweating. Your blood vessels dilate. A whole bunch of stuff happens. If you go into a cold environment, that's also a stressor, right? And you respond to that exactly the same way by releasing these same stress hormones, and they trigger a different series of adaptations or responses like shivering and reducing, contracting your blood vessels and all that. And if you are stressed about not being able to pay your rent at the end of the month, okay, that is also a stressor. You release cortisol, etc. If you
perfect.
Right, so all of these, like whatever the source of the stress, right? Whether it's a thought that you think, okay, whether it's
just amplifies it,
right? It all draws on the same central reservoir of your ability to adapt, right? If you have a lot of, say, family stress going on, okay, and you're not sleeping well, and you haven't been eating or exercising, all of those things are stressors, right? And then you get a little inflammation in your back that normally would not be enough to cause any kind of symptom whatsoever, right? Well, now maybe what happens is we pour in some, lack of sleep into your cup, okay? We pour in some financial worry, okay? We pour in some negative pain beliefs, like anytime I get a pain in my back, that means I'm doing damage to my back, okay? You had a fight with your partner, okay? Okay, and now we pour in some tissue status. Okay, so maybe you sit in one position for a long time and you don't move your thoracic spine, and the muscles in your thoracic are contracted, isometrically for the whole time, and they start to become a little bit ischemic. The word basically not enough oxygen getting to it, right? When you sit on your butt without moving for an hour, your butt starts to get sore and you have to shift around to get comfortable, right? It's because there's not enough blood getting to your butt muscles, not enough oxygen. So they yell up at you going, hey, not enough oxygen down here, help us out, move position, right? So maybe there's a little thing there that would normally not cause you any pain. It would just cause you to kind of fidget around and change position a bit and you wouldn't even notice it. But because of all of these things, okay, have turned up the pain sensitivity dial, okay, maybe this is now perceived as painful, where in the absence of all of this, if you were went to the Maldives and, sleeping in every day, getting fed breakfast and fanned by a banana leaf, okay, maybe you wouldn't have any pain. And a lot of times people report that is when they go on holiday, their pain goes away.
Got it. I do have, so I have 2 more questions. They're pretty lengthy.
I don't see any other questions in the chat. So let's keep it going.
Okay. So my second question is, I have noticed a lot of movement in my spine where I do have my fracture. And usually it's along with rotation, and it doesn't hurt, but I do hear more adjustments, more of those bones bumping into each other, or I don't know what it is, but I feel
Clicking
it's there. Yeah, the clickety, and it's in my lumbar, L4, L5, S1. I also feel it when I do leg raises, and I hear the little click. And that's just, it seems to be progressing more and more. And I went through a period where I stayed inactive for 3 years because I was I'm really, really terrified of this, and I thought my life was over. But so I started to move again, and I just started to move, and I noticed that all these things are happening now. And even though I started off slow, it just seems like there's more sounds than there should be. And every doctor that I keep on seeing, they're like, well, you should be stabilized and you should be able to control it a little bit more, but it just seems like that's not the case. And it seems like it's progressing more.
Well, I want to reassure you about both of those things. So the two things you said are there's a lot of movement in that part of your back, and the second thing is there's noise. This makes clicks and pops and cracks and things like that. So first thing is that's actually the part of your spine that has the largest range of motion, and that is because of the shape of the facet joints. The shape of the facet joints in the lumbar spine, particularly in the lower lumbar, is such that they permit a lot of extension. So if we look here are the facet joints. Okay, and you can see that in here they allow a lot of extension because they kind of face inwards. Okay, those facet joints kind of face inwards. Okay, so they allow that extension, they allow it to slide. And here's the L5, they face even more kind of this way. Okay, so you get a lot of extension in the lower lumbar spine. Okay, compared to, say, the mid-thoracic. Okay, so here's a couple of mid-thoracic vertebrae. This is the T10, T9. Okay, you can see the facet joints, they face, here's the facet joints. Okay, they face just about completely backwards. Okay, so if you look at the facet joint here, okay, in your thoracic, okay, when you extend, the facet joint just hits the other facet joint, plus the spinous process, okay, bumps into the other spinous process. So the thoracic spine actually doesn't have the mechanical ability to extend more than about 10 degrees. Okay, it's got about 10 degrees range of motion from full flexion to full extension. And we can see that when we look at a whole spine, okay, which, obviously this is a plastic model, doesn't have ligaments or muscles or whatever, but it's got the shape of the vertebrae, okay? And so if I just hold this at one end at top of the thoracic and the other end on the sacrum and push my hands together, what happens? Almost all of the bend is in the lumbar spine because the shape of the facets allows it, and in the thoracic spine it just doesn't bend, right? The thoracic spines don't extend. They rotate very well because the facets allow that, and the lumbar spine doesn't rotate very well because the facets don't allow it. But having more movement in your lumbar spine is completely normal, okay? And it's also completely normal to have particularly more at the L5S1, right? Just because of the shape of the facet joints. So there's nothing to be concerned about. That is just normal. The second thing is the clicking and the popping, okay? There are a few things that could be, okay? And what I suspect, based on what you've described, is it's the tendon of the psoas muscle flicking across a transverse process or some other, maybe an osteophyte on your spine. So if we look at from the side view, okay, here's the sacrum, okay, L5, L4, L3, L2, L1, T12, 11, 10, blah, 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 okay. Here is your psoas muscle. Can't remember which one of these was the L1, but let's just say it's that one. 5, 4, 3, 2, 1. Yep. So the psoas muscle runs down like that. Okay, and there's it inserts into your lesser trochanter there. Okay, so this is the psoas muscle side view. Okay, now as you move your leg, obviously the psoas muscle kind of goes this way, then it goes back this way. Goes out to the side, it goes in. So it kind of, moves around there. And the thing is that often these vertebrae have little bony projections on them, which are just a normal part of human variability, called osteophytes. Okay, that vertebrae have little pokey outy bits, and I don't know if that's a bug or not. Okay, but it's pretty normal. So these are exact models. These are plaster casts, these vertebrae, by the way, of an actual human spine. So this is like this was somebody's spine. Obviously, these are just plastic models, but they're very expensive ones that are modelled on an actual one. So this is pretty accurate to represent, what you see on somebody's spine. So if you imagine the fibres of psoas, okay, coming down here, okay, and then you move your leg and they go flick, flick, flick across that osteophyte, okay, and maybe it's not the fibres, maybe it's a tendon, okay, maybe it's the tendon of psoas that flicks across that osteophyte, okay. Well, a tendon is like a thick, it's like a bass guitar string, dong, 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 right? And so I reckon what you're hearing as you circle your leg around is just your bass guitar string getting plucked, okay, by probably just a little osteophyte on your spine somewhere, which is completely normal, and we all have them, and yours just happens to be in the way of your psoas tendon. Right, I actually have the same thing, my right leg, but not my left leg, right? I have absolutely zero back pain, leg pain, hip pain, no pain at all. I get some shoulder pain sometimes, but no back pain. And I get that thunking and clunking and all of that. My abs are plenty strong. My legs are plenty strong. Yeah, so it's very common. I mean, show of hands, and just use your little emoticon if your screen's off to put your hand up. Who gets, clicking, clunking, thunking in their hips / lower back? It's like freaking heaps of people do, right? It's super common. So, yeah, I wouldn't worry about it.
Okay. I do have, so my ab muscles.
There's one other question here which I just want to get to before we come back to this.
Okay.
So from Ashley, what's the best way according to the literature to increase the size of the pain cup? Or if the pain cup size can't change, what does the literature say is the best way to offload stuff from the cup? Great questions, Ashley. Ashley, those are awesome questions. So the way you increase this, you get a bigger cup, okay, is you build physical capacity. Okay, so when you have more physical capacity, you have more physical capacity to tolerate stress. If you're stronger, if you have better nutrition, all of those things, right? You build physical capacity. Okay, so how do you build physical capacity? Well, that's what we do, right? We challenge the body, to get stronger, better endurance, more flexible, more control, all those things. We build physical capacity, and that has to be paired with good nutrition and rest, okay? And it's like, well, what are the things that give you more ability to tolerate stress in your life? Well, I mean, we all know these things, right? It's like, well, sleep, quality time with loved ones, good nutrition, what are the things that feed your mental health, spending like quality time with friends, doing things for other people, feeling like you're making a difference in life, feeling supported by the people who you care about, all of these things are important, right? And then there's things like, okay, so we build up our cup, so we, think what are practical strategies you can use to improve your sleep, to improve your relationships with loved ones, to spend more time doing things that are meaningful for you and that, give you joy and feed your passion. All of these, what is something you could do to improve your diet? Again, not for like aesthetics or anything, but just like eat more veggies, eat less processed food, drink more water. All of those are just normal good things that we all probably agree are valuable and make us feel more healthy and more resilient physically and emotionally. What some things like, what do you do in your life to have fun? Do you laugh? Do you spend time with dogs or kids or, whatever? Like, do the stuff that makes you more resilient and healthy as a whole human, okay, more mentally, physically, and spiritually healthy. And then there are also things you can do to reduce the size of the stuff that you're pouring into the cup, or mitigate the things that you're pouring into the cup. So, all right, so, if you've got, say, financial stress, okay, well, go talk to a financial advisor, solve that shit, right? If you've got, mental health issues, well, there are lots of things that can help mental health, like going for a walk in nature, doing a Pilates class, talking with a friend, doing something for somebody else. All of these are good. And go get some help from a mental health professional. Like we can do all of these things. It doesn't mean either or, so you can do all of these things. So basically, yeah, and there are like things that we can do to mitigate stress that are things like, and we all know the things, right? Like you know when you have a shit day and your monkey mind's going 1,000 miles an hour, that there are certain things that if you do them, they calm you and center you and take that away, right? And it's going to be a little bit different for each of us, but basically similar. It's like, well, what about meditation? What about taking a bath in a dark room with some candles and listening to some classical music? What about progressive muscle relaxation and, diaphragmatic breathing? What about, spending some time, reading a book that, causes you to reflect on the purpose and value of life? What about journaling? What about, there's so many things. What about going for a walk? What about having a glass of wine with your loved one? What about, patting a dog? There are so many things that mitigate stress. And I bet if I asked you to write a list of the things that predictably 100% chance, if you do those things, you feel better after. It's like you could come up with a list of 4 or 5 things. We'll just do more of those. Like in case of emergency, break glass, like go meditate or walk your dog or whatever, whatever the thing is for you, do a Pilates practice. So yeah, that's how you do it. And when we zoom right out, okay, to like Earth orbit, so all of the details are gone, okay, that looks like reassurance and advice to stay active, okay? And if we zoom in a bit closer, so it's a little bit of the detail comes in, what we see is it looks like strengthen, build the physical capacity, okay? Not just strength, but, nutrition, all of those things that build physical capacity, and then also build psychological resilience. And psychological resilience is comprised of optimism and focus on your own strengths and the ability to overcome things, on social connections and meaningful relationships, on your mental flexibility. Okay, not having to do things a certain way, but knowing like, okay, well, I know I'm going to succeed here. I'm not exactly sure if this doesn't work, I'll try something else. Okay, or I'll change my mind, but I'm not going to give up, but I'm totally open to changing tactics. Okay, so those things are components of psychological resilience, and you can foster that by affirming your client, pointing out their strengths. You can refer them to mental health professionals. You can encourage them to do the things that feed them, emotionally and physically and socially. It's like just all of those things. Be a healthy human. Okay, so those are the things. And there's not one, it's not that nowhere in there does it say like activate your multifidus better or anything. It's just like be a better human, a healthier, more resilient human. And I think, we all know the things that contribute to that, right? It's just back to basics. All right. And Ashley says, having those conversations with clients within our scope of practice, 1,000% they are. It's not your scope of practice to counsel a client for their mental health, okay? But it is totally within your scope of practice to say, well, how you been feeling lately? Are you under a lot of pressure? Is your mental health impacting this, do you think? That's not counselling. That's just being human and caring and showing them that you give a shit and acknowledging that they're not just a pair of spinal bones in a certain alignment, that they're actually a whole human with a brain that makes meaning and has emotions and expectations and all the rest of it. And so, yeah, talk to them about this stuff. Don't counsel them. Okay, don't say, oh, I think it was when you were a child, your mother never blah, 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 right? That's outside your scope of practice, okay? But you can say, oh, well, what are some things that make you all feel calmer when you do it? Oh, meditating. Okay, well, why don't you do more meditation? That's helping them come up with a practical strategy to solve their issue, right? And if you feel like you're out of your depth with their mental health issues or whatever, we'll just refer them, right? Doesn't mean you have to stop working with them. Refer them to a mental health professional and you can continue to see them. Yeah. So, yeah, I'm sorry. Was there one more question still, or are we done?
I do have one.
Okay. This is the longest one.
It's related to the central sensitization that we were talking. I know that it's related to this long response that you have given to Ashley. Is it expected, the central sensitization, to get better within the time, even if we are not doing anything about it? Like we were talking about the bulging or hernias or whatever. But when we come to that time when there is the central sensitization, how are we supposed to handle that if it's also with all those best practices that you have been talking about? Or
Just the same
if
thing.
we do
It's just the same
nothing,
thing.
it is expected to also get better with time?
Central sensitization is tricky. And the best, we certainly don't have a silver bullet for it. And the best practice is just what I've outlined. The things that calm the nervous system are the opposite of the things that sensitize the nervous system, right? So the things that sensitize the nervous system, stress, lack of sleep, inflammation, lack of physical activity, worry, poor mental health, all of these things sensitize the nervous system. So what calms the nervous system? Well, getting good sleep, not worrying about things, feeling, calm and fearless, being optimistic and, calm, having good mental health, getting regular exercise, eating a good diet,
Same
all of
thing
these things.
as you were recommending to actually, okay, yeah. And
Yeah.
the other thing is, can we say that it's because of central sensitization? Because I don't know if it's a way to diagnose. You don't have hernia, or your pain is coming from the hernia, but for the central sensitization that you are experiencing, is there a way to diagnose that this is the root cause of the pain experience?
So for Pilates instructors, we shouldn't diagnose anyway, unless you're a medical doctor or a physical therapist. But it really doesn't matter, because even if you had, just say you had digestive symptoms and you had Crohn's disease and you had 6 feet of your large intestine removed and a colostomy bag put in, well, should you get regular exercise? Should you get good sleep? Should you eat well? Should you have good mental health? Should you meditate? Yeah, yes, right? So it doesn't change the treatment, right? So the treatment is the same regardless of the diagnosis, right? Just support the whole person to become more physical capacity, more psychological resilience. That's the same regardless of the diagnosis.
Okay, thanks.
Great questions. Thank you so much, everybody. Really enjoyed this conversation. Hope you got a lot from it. If you're watching the replay and you've got a question, you can ping me on Slack. Oh, sorry, not on Slack, on social media, on Instagram. I guess if you're watching this, you probably already follow me on Instagram, but maybe we'll put a link to my Instagram in the description, and you can DM me or whatever on Instagram if you've got a question. All right. Have an awesome day, night, afternoon, whatever time of day it is for you, and I look forward to seeing you soon. Bye.